Welcome to this video. Thank you for coming back. Now, right from the start of this pandemic, we've known that COVID-19 causes a pneumonia. And pneumonia is infection and inflammation right down in the lungs, in the alveoli, in these microscopic air sacs in the lungs. But it's also becoming increasingly apparent, and has been for some time now really, that it's also a disorder of the blood vessels as well. And this disorder of the blood vessels, which is caused by COVID-19, makes it more likely that the blood will clot. It's what we call a coagulopathy. Pathy's disease of it. The blood is more likely to coagulate, more likely to clot. And if the blood clots in the small vessels, that means the blood can't get round the blood vessels in the lungs. That means you can't get enough blood to the lungs, to the alveoli, to pick up the oxygen to take it back to the body. And that's one of the reasons that the levels of oxygen in the blood drop, causing a hypoxaemia, a reduction in the level of oxygen in the blood. And of course, these small thrombi, a thrombus is a clot that forms in the blood vessels. These small blood clots, these small thrombi, can also reduce the circulation to other vital organs as well as the lungs. For example, the brain, the heart and the kidneys. And we know that these organs can all be affected. And it's becoming increasingly obvious now that patients with COVID-19 are more likely to get the big blood clots in the veins of the leg that can lead to blood clots on the lungs. So all this is very interesting, but what does it actually mean? What's the significance of this? Well, it's absolutely vital, because it means for years we've been given drugs that thin the blood, these anticoagulant drugs that we use routinely. I've been using anticoagulant drugs for about the past 40 years now. These are routine, standard treatments that we give, and we're well skilled in giving these. So that means we can treat this coagulopathy. We can reduce the clotting of the blood. So that's what this video is about. It's about a couple of scientific papers that kind of explain this in detail. Now, I know that's not for everyone, so that's why I've given you that bottom line there first. That COVID-19 is a pneumonia. It affects the lungs, but it also affects the blood vessels. It also causes clotting, and it looks very likely that by giving anticoagulants we can reduce the risk of this clotting. Just in the same way that we can give dexamethasone to reduce the inflammation in the lungs that causes the acute respiratory distress syndrome and the severe acute respiratory distress syndrome. So we can treat this disease now at these two levels. Now, to be fair, the dexamethasone has been trialled. We've got trial data on dexamethasone. We haven't got the trial data yet on the anticoagulants. That's why I want to give you this information, but it's looking like a very promising treatment. And what this means is it's so important. That means with simple treatments now, with oxygen therapy, with antibiotics if we get secondary infection, with intravenous fluids if we get dehydration, and with dexamethasone, we can treat this condition quite effectively in many cases now. And if the anticoagulants are working, we can reduce the side effect of the microthrombi that are occurring, these micro blood clots that are occurring. So it really is some quite important stuff. So if you want to skip this video now, that's the important bits. These supportive treatments are going to be vital. But of course, that means that these supportive treatments have to be available. Now, if you live in a poor part of the world and you don't have access to these supportive treatments, then your probability of dying with a particular level of pathology is greater. And it also means that if we have many cases all at the same time and the health services are overwhelmed, then your chances of dying are greater, because you're not going to get the essential supportive care that you need. So quite severe implications there for poor parts of the world which need support, but also shows why it is so vital that we slow down the spread of this disease in areas like the United States, like Brazil, like Russia, like India, where it's spreading fast now. So we can give these relatively simple supportive medical treatments to everyone that needs them, and thereby greatly lower the case fatality rate. That is the hope. Now, moving on to the detail. Now, this is a paper from It's coagulation disorder in COVID-19, and it's from the Lancet, and it's published on the 10th of July. Which camera am I on? This one. Published on the 10th of July. Just experimenting with extra cameras. So up to date publication, the latest thinking in the field. Now, it starts off by summarising that in severe COVID cases, we know there's the SARS, the severe acute respiratory syndrome. So that is known about, and the severe acute respiratory syndrome is where all the acute, I normally put it the other way around, don't I? I normally say acute respiratory distress syndrome. So the severe acute respiratory syndrome is the name of the virus, actually. It's the SARS coronavirus 2. But the acute respiratory distress syndrome is the complication that it causes. Now, in the acute respiratory distress syndrome, as we know, the alveoli, these small air spaces in the lungs, they become inflamed and they can fill up with fluid. So that is known about, and that's a cause of hypoxia, of course. That's known. And this can cause severe dyspnea and hypoxaemia. Now, dyspnea, DYS means difficulty. Pnea means air. So difficulty in breathing is what dyspnea means. And hypoxaemia is low oxygen in the blood. Emia with an A in English. So we know that it can cause difficulty breathing and hypoxaemia with the acute respiratory distress syndrome. But right from the start of this, it's been noted that some people who have low oxygen saturations, they can have low oxygen saturations, but they can be talking quite nicely and don't seem to have any great respiratory symptoms, indicating there's another cause for their low oxygen saturations. And this is what seems to be happening. So here we have the alveoli. So that's the alveoli, these microscopic air sacs in the lungs. They're elastic, the air goes in and out. Now what we have is the air goes in and out of here. So the air goes in there and out there as we breathe in and out. Now approaching this, we have a small blood vessel, and that's called a pulmonary arteriole. It's a small arterial vessel, and that's taking blood to the alveoli. And then what happens is these break out into hundreds of small capillaries called pulmonary capillaries. Like this, I've only drawn two to make the diagram simple. So what happens is the blood actually goes from the pulmonary arteriole here through these capillaries, picks up the oxygen, and then it drains via the pulmonary venule there, going back to the heart. So that's how the blood normally picks up its oxygen. So first of all, it makes sense that the amount of oxygen that's getting into the blood, because remember, if there's not enough oxygen here in the blood, that causes the hypoxia or the hypoxaemia. The hypoxia technically is deficiency of oxygen at the level of the tissues. So the blood goes in there, picks up the oxygen and leaves there. And of course, at the same time, it gives up the carbon dioxide. So it makes sense that if there's inflammatory changes in the alveoli here, if there's inflammation in the alveoli here, and these are inflamed, and this inflammation causes the accumulation of fluid in the alveoli, and this fills up with fluid. As we've said, that is the acute respiratory distress syndrome, as the alveoli fill up with fluid. But this doesn't appear to account for all of the hypoxaemia in many patients. So what it now seems is happening is that the inflammation is also affecting the walls of the small blood vessels. So the small blood vessels, the walls of the small blood vessels are getting inflamed as well. And that's actually triggering off some blood coagulation. So we're getting coagulation of the blood in some of these capillaries. Now, if you get coagulation of the blood in all of them, of course, it'll kill you. But if you get it in some of them, Can you see that means there's less blood flowing through the lungs, so there's less oxygen in the blood that comes out of the other side into the pulmonary veins to go back to the heart. So that looks like the other part of this pathology here, that these micro blood clots are reducing the circulation to the lungs, thereby reducing the amount of oxygen getting to the lungs. So it seems to be those two things going on. So, there we go. So we know about this dyspnoea and hypoxaemia, and we know that sepsis or severe sepsis is another complication of COVID-19. And sepsis is the complication of infection, and septic shock is when the blood pressure drops as a result of the infection. And we know that the combination of these things can lead to life-threatening organ dysfunction. Now, it now appears that the organ dysfunction, such as the dysfunction of the organs like the heart and the kidneys, that can be caused by the reduced amount of oxygen getting to them as a result of the hypoxaemia. But it also looks like that these small blood clots can be occurring in the blood vessels that supply the heart and the blood vessels that supply the kidney, or indeed the blood vessels that supply the brain. And again, if some of the small blood vessels are blocked off with these blood clots, that's going to reduce the blood supply to these vital organs. So the organs can be damaged in severe cases as a result of the sepsis and the septic shock, and as a result of the reduced blood supply and the hypoxaemia, the reduced oxygen supply. Now, there's different ways to classify this now, but people are often now talking about mild COVID-19, moderate COVID-19, severe COVID-19, or critical COVID-19 infection. And of course, we also know there can be a completely asymptomatic form as well. Many people get asymptomatic forms. So what this paper is telling us in the Lancet here is it's telling us that there is increased blood clotting. There is an increased likelihood that the blood will clot in COVID-19 disease. Increased blood clotting, a coagulopathy. So COVID-19 infection is associated with coagulopathy. So pathy, whenever you see pathy means disease of. Obviously that's to do with coagulation. So there is a disease of the coagulation of the blood, meaning the blood is more likely to clot. There's a coagulopathy. So COVID-19, as well as causing acute respiratory distress syndrome, can cause a coagulopathy. And completely varying degrees. This can be very mild or it can be very severe. Similar to the changes observed in sepsis-induced coagulopathy. So sepsis-induced coagulopathy is where people's blood clots because they're septic, or this other one, disseminated intravascular coagulopathy, that can be caused by sepsis or it can be caused by trauma or other disease processes. And I know these have got big words, but they're well known about. So sepsis-induced blood clotting, or disseminated means that there's blood clotting. Vascular, in the blood vessels, in the blood. So there's clotting in the blood vessels that shouldn't be there all over the body. Coagulopathy. Pathy, disease of. And these are well-known complications of shock and sepsis and trauma. So these things are well known. And COVID-19 seems to be doing much the same thing. But you can see the advantage here is because these things are well known, we know how to treat these. There's accepted treatment protocols for these. Severe coagulopathy was associated with severity of COVID-19 and mortality in some studies. So in other words, the more likely the blood was to clot, the more likely the person was to become very sick and potentially to die. So some studies are showing that the severity of the disease is caused more by the blood clotting in the small blood vessels than it is by the fluid collecting in the lungs. In actual fact, it's both, but it's interesting that there are correlations between the increasing likelihood of the blood to clot, the coagulopathy, and the likelihood of the patient not surviving. Now, coagulopathy is associated with endotheliopathy. Now, you don't need to know all these big words really, but coagulopathy is disease of the blood clotting. It's associated with endo is inside, thelial is lining, and pathy is disease of. So what we have inside blood vessels, all blood vessels are lined. They have a lining, and that lining is called the vascular endothelium. The vascular endothelium. So if there's disease of this vascular endothelium, then that is a endotheliopathy, an endotheliopathy. And that's what seems to happen. The COVID-19 virus, or the body's immunological reaction to the COVID-19 virus, causes inflammation in the vascular endothelium in many parts of the body. And this inflammation means that the red cells which are going through here are supposed to go through in nice separated form like that. Means they'll start clumping together, and we'll start getting these blood clots. And we can see now that that blood clot has blocked off that vessel. And another name for a blood clot is a thrombus. So coagulopathy is associated with an endotheliopathy and causes a thrombotic. So thrombotic is to do with the thrombosis. That's the blood clot. That's the thrombosis there. These words are actually dead simple. Just doctors use them so that the riffraff don't know what they're talking about. I've had this problem for years. They're actually not hard. And it also causes a micro. So micro is small. Angio is blood vessel, and pathy is disease of. So microangiopathy is disease of the small blood vessels, and that's what's happening here. Disease of the small blood vessels causing this thrombosis. So coagulopathy, the increased likelihood of the blood to clot, is associated with an endotheliopathy, the disease of the endothelium, that causes blood clots, a thrombotic microangiopathy, disease of the small blood vessels, and therefore microcirculatory impairment. So this is impairment of the circulation at the level of the arterioles and the capillaries, the small blood vessels. It's not so much, well, it is, the large vessels are infected as well, but that bit's saying it affects the small vessels, but it affects the small vessels all over the body. So for example, let's imagine there was an area of the heart where the blood supply was reduced. Can you see if there's not enough blood supply getting through to areas of the heart, then that would cause what we call an ischemia, a reduced blood supply. There would be an ischemia. And if that's affecting the heart muscle, that's called a myocardium. The myocardium is the heart muscle. So that could cause a myocardial ischemia. And if the myocardial ischemia was bad enough, that could lead to actual damage and death of the heart muscle, some of the heart muscle cells. And this does seem to happen because when the heart cells die, if that's the heart myocyte, the contractile cells in the heart, if some of these die, they release a component called troponin. And troponins have been discovered in patients with severe COVID-19, indicating that there's a thrombotic endotheliopathy causing a microangiopathy in the small vessels of in the small coronary vessels that supply the myocardium. Now, post-mortem findings of microvascular, platelet-rich thrombotic deposition in small vessels in the lungs and other organs. So this has been found in post-mortems. So the small vessels, these capillaries that are taking the blood around the alveoli to pick up the oxygen, are clotting. The blood's clotting inside them. And obviously that means that the oxygen is not getting back to the rest of the body, so we get this hypoxia. It does all make perfect sense, actually. And the authors say this is a plausible explanation of sudden cerebrovascular complications as well. So cerebro is to do with the brain. vascular, the blood supply. So that's the blood vessels that supply the brain. So this can affect the blood vessels that supply the lungs, the blood vessels that supply the heart, presumably the kidneys, and the brain as well. And there's increased reports of both microcirculatory and microcirculatory thromboembolic complications. Now, I think I will just tell you what this means. Now, this is a very important principle generally. But what you actually have in the... you have veins in your legs there like that. So they're veins in your leg. And they go up to a large vein here that goes through the abdomen and into the thorax, and that actually goes into that vein goes into the heart. That vein's called the inferior vena cava. Taking blood back to the heart, and then that goes into that goes into the heart here like this. That goes into the top chamber of the heart. Then there's valves there. Then there's the bottom chamber of the heart there like this. Then there's valves there, but then there's an artery here that leaves this bottom chamber of the heart, and that goes to the lungs. So what can happen here? So this is the right side of the heart we've drawn here. That's the right side of the heart. If you want to know about the left side of the heart, there's other videos on that. Right. So what can happen is the blood clots. If there's a blood clot here, in the deep veins in the leg, just a blood clot. Now, if there's a blood clot there, we call that a DVT. That stands for a deep venous thrombosis. A thrombosis is a blood clot where there shouldn't be one. And then what can happen is that blood clot, bits can break away from that blood clot. And of course the blood's flowing this way, so bits break away. These bits will flow back towards the heart. And a bit that breaks off is called an embolus. It causes the condition of embolism. So emboli can break away from the thrombus. And as these emboli go back towards the heart, they're going into progressively larger and larger vessels. I mean, the inferior vena cava is the largest vein in the body by far. So the blood clot can fit through there quite nicely. Goes into the right chamber of the heart there, the so-called right atrium, down through these valves into the right ventricle, pumped out, and this is the vessel that takes blood to the lungs. Now, when that leaves the heart, it divides into two very quickly because, of course, one goes to each lung, like that. But then these vessels divide down fairly quickly into smaller blood vessels in order to take blood to all of those small pulmonary arterioles that we looked at here. To take blood to these small pulmonary arterioles. So what happens is that, and of course these are getting progressively smaller. So as the blood clot goes through the pulmonary artery, or eventually come to a vessel that it won't fit through. And what that will do is that will cut off the blood supply to a part of the lung that is normally taking blood to. And that is a condition called a pulmonary embolism. Pulmonary because it's in the lung. Embolism because it's the emboli arise from the original thrombosis here. So this condition is called VTE collectively. It's called venothromboembolism. Venothromboembolism. So what it means is that blood clotting in the veins can cause the blood clot to move to the lungs. So the deep venous thrombosis can result in a pulmonary embolism. Deep venous thrombosis can cause a pulmonary embolism, and that's in the pathological process called venothromboembolism, which is the overall description of it. So this is also more likely to happen. So what we find in COVID-19 is there's an increased likelihood that we'll get clotting in the small blood vessels, but there's also an increased likelihood that we'll get blood clotting in the larger blood vessels as well. And if it's in the veins of the leg, for example, that can lead to pulmonary embolism. which is another potentially fatal condition. So increasing reports of both microcirculatory and macrocirculatory thromboembotic complications. So micro is at the level of the arterioles, venules and capillaries. Macrocirculatory is the large vessels. Basically, we say something's macro if you can see it. So like in your fingers here, you've got lots of capillaries. So you press that, you see that goes white. This is a test called capillary refill time. And what's actually happening is, when it goes white, you are squeezing the blood out of the capillaries. But then when it goes pink, that's the blood coming back into the capillaries. But that's on such a small scale, you can't see the individual vessels. Whereas if you rip open the leg, you can tear out these large veins. You can actually see them. So basically, microcirculatory, I classify that really as vessels that are too small to see. You can't see the individual vessels with the naked eye. But macrocirculatory is you can see these vessels with the naked eye. That's a reasonable distinction between the two. High incidence of venous thromboembolism in hospitalised patients with COVID-19. In other words, they're more likely to get deep venous thrombosis complicated by pulmonary embolism, which is a life-threatening condition, particularly in those with severe illness. So we see that these patients are more likely to get small blood clots, diffuse all around the body, but more likely to get big blood clots as well. And this does explain that early on in this illness we did come across people that were suffering from cerebrovascular accidents when the blood supply to the brain was cut off, causing stroke. Similar to the high rates of venous thromboembolism is observed in patients with other viral pneumonias. So again, this is something that we know about. This happens in other viral pneumonias. And it's also been documented in severe acute respiratory syndrome, SARS 2002-2003, and Middle East respiratory syndrome from Campbell's as well. The other two severe pathologies caused by the coronaviruses. So there we go. Now, what are the implications of this blood clotting? Well, we're actually very good at preventing blood clots. So thrombosis is the blood clots. Prophylaxis is a treatment we give to prevent something from happening. It's a preventative treatment, and we can do this. And we do this routinely all the time. This is absolutely routine treatment. So this is from Scientific and Standardization Committee of the International Society of Thrombosis and Hemostasis. In other words, this is the big boffins in this field that make the international declarations and say what you do. Now, the reason that this group are piping up on this is a remarkably good one. There's a good reason for this. Because there are randomized controlled trials underway now in patients with severe COVID-19 disease to see if giving them large therapeutic doses of anticoagulant drugs is going to improve mortality. Now, I really believe it's going to, and I think everyone else believes it's going to, but we don't know until we've got the trial data. The reason I can tell you dexamethasone works is because we know it works because we've got the trial data. On this, we haven't got the trial data. So what do? We've got sick people now, we've got people dying now, but we haven't got the randomised double-blind control trials to prove efficacy. So what do? Well, what we do is we use expert opinion. Now, of course, you can go to your local hospital and talk to a senior physician who is an expert, of course, and he's much more likely to have a good idea about this than you or I. But it's much better if you can get expert opinion that are based on international agreements. So that's what these groups are for. That's what these groups are so good at. These groups. So all the major boffins get together. And they say, right, this is what we think. This is the best explanation of the evidence so far. And this is what they're saying while we wait for the trial data. And this does make perfect sense. So what they're saying is a change of anticoagulant regime from prophylactic low molecular weight heparin. Right, so let's explain that first. So let's explain that bit. So a change of anticoagulant therapy, a regime, from prophylactic low dose. So what we often do for poorly people, we give them a low dose of heparin, and that makes the blood a bit less likely to clot, and that makes them less likely to get venous thromboembolism, less likely to get deep venous thrombosis, less likely to get pulmonary emboli, less likely to die. So that's what we do anyway. We give a small dose of, and the low molecular weight heparin is the drug that we give. That's the actual anticoagulant drug that we give these days, if we want it to work quickly. Now, there are others that take longer to work, but that one works quickly. Or sometimes we give an intermediate dose if we're particularly worried about blood clots. So this is advocating or suggesting a change of anticoagulant regime from prophylactic low molecular weight heparin or intermediate dose. So instead of that, we go on to a treatment dose. This is a much larger dose that will cause a much greater anticoagulant effect and make the blood much less likely to clot. So the prophylactic dose and the intermediate dose make the blood a bit less likely to clot, but the treatment dose makes it much less likely to clot. So two treatment doses regimes can be considered in patients without established venous thromboembolism. Now what this means is that in patients with established venous thromboembolism, like a deep venous thrombosis or pulmonary embolism, would go straight on to give the higher doses, the large anticoagulant doses. So that's saying even if a patient hasn't got that, but if they've got deteriorating pulmonary status or acute respiratory distress syndrome, then this should be considered. So what these experts are saying is that deteriorating breathing status, deteriorated pulmonary status, or acute respiratory distress syndrome can be treated by giving anticoagulants. Or they're suggesting that that is considered while they wait for the trial data. So that means that these patients can be greatly supported by giving them dexamethasone to reduce the inflammation and anticoagulants to stop this blood clotting. So if the anticoagulants stop this blood from clotting, then the circulation to the lungs can be maintained. And in actual fact, this blood clot will, the body will remove that itself reasonably quickly if it's a small one as well. So while anticoagulants do not break up blood clots, they're not thrombotic. They're not thrombolytic. They don't break up the blood clot. They stop it from getting any bigger, and the body can dispose of the blood clot it's got. So there you go. Well done if you watched all that. If you watched all that, well done. What we're saying is it's now getting clearer. This virus is having two main pathological effects on the body. One is the pneumonia, and the other is the disorder of the small blood vessels, making the blood clot in the small blood vessels. And we can prevent the inflammation in the alveoli with the dexamethasone, and we can stop the blood from clotting in the small blood vessels with therapeutic doses of anticoagulant, both well established, well understood, supportive treatments that have the potential to massively reduce the case fatality rate in those that are critically ill with COVID-19 disease.